This is Selma Schimmel for the Group Room at the ESMO 2012 Congress happening now in Vienna, where we are now joined by Dr. Stephen Grunberg, President of the Multinational Association of Supportive Care in Cancer, also known as MASC. Hello, Dr. Grunberg.
It's a pleasure to be here. Thank you.
Would you define for us what is supportive care?
Supportive care is a general term that has been used to mean many different things by many different people. We consider it to be everything about the care of the cancer patient other than the actual administration of cytotoxic therapy, surgery, radiation. It's everything that surrounds that. But we would say that good supportive care makes the rest of cancer care possible.
What are some of the greatest obstacles that you face in this whole area of supportive care, both with patients, with providers, public perception, attitudes?
Like everyone else, we are limited by the resources that are available for the treatment of the cancer patient. We certainly want to do as much as possible for our patients, but the question is, what does that actually mean? Some of the obstacles we run into are people, and this could be patients or it could be providers, who might feel that this is somehow less important than killing the cancer itself, where in reality it's all part of the same picture. We also run into the perception, sometimes among patients and sometimes around doctors, that the side effects of cancer treatment are actually necessary for the efficacy of treatment, and that is totally untrue. Vomiting after chemotherapy never made your chemotherapy work better. But you will find that people somewhere deep down, and again, we've done surveys that looked at the obstacles to care, there are patients who believe that that's exactly what the vomiting means, that their chemotherapy is working better, and they would fear to lose that for fear that their chemotherapy would not be working. Unfortunately, we've also found that some providers believe the same thing. We are trying to convince people or explain to them that we can separate these side effects from the treatment and still have the efficacy. The modern form of that is actually with the new targeted therapies. For example, the epidermal growth factor tyrosine kinase inhibitors. It is well known from the early trials that if you get a rash from these agents, you are more likely to respond. That has been assumed by many people to mean that you must get a rash to respond. From the supportive care side, we would say what that means is that we have not learned how to control the rash yet and maintain the efficacy of the drug itself.
So without proper supportive care, I think what happens is that the patient becomes entirely demoralized.
It's that general term that we refer to as quality of life. All of us know what it is, none of us could really define it. But that's what we're talking about. It's whether you feel that you can function and keep on your normal life. Cancer in English is considered to be one of the 3 most frightening words in the English language. And the one, if you hear that you have cancer, your whole world comes to a halt. You do become separated from the world, separated from your friends, separated from everything. And maintaining a normal life and maintaining a normal quality of life is certainly a worthwhile goal. Not to replace curing the cancer, but rather, if possible, to be part of it.
Cancer patients also need to be very careful about their nutrition. It's so hard to have decent nutrition if nothing tastes right and you have no appetite.
This has to be addressed on many different levels. The first is the question of nausea itself. We have made incredible progress in the control of chemotherapy-induced vomiting over the last 30 years. You would usually hear it called control of chemotherapy-induced nausea and vomiting. But if you look closely at those studies, what we were really measuring was chemotherapy-induced vomiting. Vomiting is at least 90% less than what it was 30 years ago. But we are only now realizing that we were not really addressing nausea. And that's for many of the reasons you say, that nausea can mean so many different things to so many different people. There are so many different terms in English, so many different terms in every language for what we might call nausea, and it means something different to each individual. It can certainly be debilitating. One of the major advances or ongoing advances is our realization that nausea is a different problem that may require different remedies. We're actually coming to realize that some of the drugs that we called antiemetics are very good at controlling vomiting, not very good at controlling nausea, while there are other drugs that were put to the side because they were not very good at controlling vomiting, but they may be very good at controlling nausea.
I'm curious for our viewers, can we talk about some of those drugs? Because I bet some of those have been around a long time.
They have. Corticosteroids are the simplest example, which probably do more for nausea. Megestrol acetate has shown to have some effect against nausea. Cannabinoids, which are only moderate, very moderate drugs with significant toxicity if you try to go to the high doses to control vomiting. At very low doses may be good for controlling nausea, and olanzapine is a new one that's also being considered. If you look at these drugs, you will find that many of them were also used as appetite stimulants. But if you think about it, what would the opposite of nausea be? Probably having a good appetite. So this is a whole new area that we're only now beginning to explore, and which we hope will also benefit our patients, because as you say, the continuing nausea may be an even bigger problem than the vomiting itself.
Do we even understand what is the basis of that ongoing nausea that can last for some patients 10 days after treatment?
We know that the nausea is related to the vomiting because drugs that control vomiting do control nausea to a certain extent and vice versa. So we understand the similarities. What we don't understand is the differences. And this is really new areas because some of the agents that I mentioned really do not affect the standard receptors that we think of as being those in the emetic pathway. So we're really now looking for new pathways and different pathways so that we can more appropriately and specifically target those pathways to get more effective agents.
What do you want our viewers to understand about how they can best advocate for themselves in dealing with their physicians and trying to have discussions about their quality of life and their supportive care needs? Because I imagine for each individual, it can be different.
MASC has 16 different study groups, each of which concentrates on a different area of toxicity. And like with your children, I would be afraid to say that any one of them was my favorite. They're all important, they're all very active, and they all face different sorts of problems. In terms of what our patients could say to their physicians, I think they should simply say, is this toxicity really necessary? Now, do I have to be going through this to receive effective treatment? There may be times when it is. At this point, if you are going to get a very strong chemotherapy, there will be, we can never say that there will be no side effects. But to say, is this toxicity really necessary? Is this degree of toxicity really necessary? If you're nauseous or vomiting, you could ask your physician, am I getting the best antiemetics I could get, or are there other options? If the patient is having bowel problems, diarrhea or constipation, am I getting the most effective remedy for diarrhea or most effective remedy for constipation that I could be getting, or could we change this? You know, for example, for diarrhea, most oncologists are used to using a drug such as Imodium, but they don't realize that we can actually use doses much higher than one would use in standard care. There are new remedies for constipation, such as methylnaltrexone and other peripheral opioid receptor antagonists that we don't usually think of, but that can be highly effective. And it's not just constipation; it's something that can be very painful and very disturbing to the patient that we can do more about than we used to. So I think that simple question: is this toxicity actually necessary? To start the oncologist thinking and looking into the literature and talking to people who have expertise in this field might actually go a very long way.
Thank you, Dr. Stephen Grunberg, President of the Multinational Association of Supportive Care in Cancer.
My pleasure. Thank you.